this is crazy. And I'm so thankful that you've said you've got to get the right diagnosis first. And the likelihood is that it's probably all of the above.
So if you're just looking at the report and you just see degenerative disc disease, they don't mention the annular tear. And it's so bright, so white, and it's ipsilateral to their pain. And you're like, well, please, you have to look at the images.
The next question is, what's the most misleading thing that patients are told about their disc problem before they ever reach someone who treats it? Welcome, everybody. This is Conversations in Regenerative Medicine, and we are exploring frontiers in PRP, BMC, and MFAT. We are excited to bring controversial topics and cutting-edge insights that are shaping the future for interventional orthobiologics. And so we're going to get started. I am so happy to introduce you all to my friend and colleague, Dr. John Knab. He is a board-certified, fellowship-trained interventional pain physician with over 2 decades of exclusive pain medicine practice. He is sought-after educator and speaker and planner of events like TOBI, IOF, RMOS, and international spine conferences. And he has successfully built a cash-based regenerative practice that is focused entirely on non-surgical solutions for spine and joint pain. And, passionate about advancing intradiscal biologics to help physicians understand what the evidence actually says. And when we first met, my favorite part of him as a human and as a person is that he is, by personal exclamation, an incrementalist. So that is one of my favorite things that you say about yourself is, we don't get too crazy. I'm an incrementalist. So that is one of my favorites. For those of you who don't know who I am Dr. Ariana DeMers. I am a board-certified, fellowship-trained sports medicine orthopedic surgeon and regenerative medicine aficionado. I do a lot of educating and training for both orthobiologics and ultrasound, and I have successfully moved my rural Northern California practice away from insurance, and I focus on cash-based orthobiologic procedures, and I am passionate, capital P, passionate about helping doctors to successfully and seamlessly integrate orthobiologics into their practices. So I'm so glad that you all are here and joining us today. This is exciting, and this is a little different. This is a little bit more informal, just amongst friends, chatting about the things that we're passionate about. So we are going to explore the controversial topics in orthobiologics and regenerative medicine, maybe gain some actionable insights that you can implement in your practice immediately. And of course, one of my favorites is participating in that live Q&A session to get your burning questions answered. So glad to have you, John. I'm so glad that this worked out for us, and I think this is going to be really fun. What a treat for everybody to have you as our human today, the hot seat, if you will.
No, it feels fine. It feels nice and cool.
Well, hey, happy St. Patrick's Day to you.
Happy St. Patrick's Day. I'm here at Patty's bar.
That's so
hopefully you can hear me over all the noise.
All the din. Yeah. Everyone's, green beering it up. So thank you so much for taking time out of your St. Patrick's Day to join us. I really appreciate it. So I wanted to share that I believe that orthobiologic treatments will be first-line treatment for musculoskeletal care in the next 5 years. And so if you are not currently offering these treatments, you got to get on the train. The train is leaving the station. And so hopefully this helps those of you who are maybe at the station but not on the train, getting a little bit further down that path. Also, having a successful orthobiologics practice is what we're looking for, but sometimes it's hard. And we know orthobiologics is the best treatment, for our patients, but how do you be successful at it? And maybe some of you have tried some things, but maybe you're not sure about the science, not sure about the techniques, not sure about cash business, marketing, sales. And maybe you've just thought, gosh, I'm just not good at business. But that is not our fault. We did not learn this in school. And so maybe some of you are struggling on how to be successful and capitalize on the $4 billion orthobiologics market out there. And some of us are thinking maybe we deserve more, but why is this so hard? So please, please, please type in the chat things that you're struggling with, cash business, finding the patients, who's a candidate, just marketing, sales, not trusting those marketers. Put that in the chat if you can, and we'll maybe talk a little bit about that at the end. So the question is, how do we win? And while we are talking about the science today, we also need to consider how we talk about this with our patients so we all win. And so we need a system, right? We're not going to go all over this system today. We're going to talk about the orthobiologic knowledge, but we do want to get you a little bit further along in this journey to be wildly successful. So we are going to start dropping some orthobiologic knowledge. So we will get started with Dr. Knab, and we're going to get down to business. So turns out, John, we have questions. And so we're going to just dive straight into our full question and answer for you, basically hot seat. And we're going to have a little bit of a conversation. So, there's this question about whether discogenic pain is actually a diagnosis, or is it more of this catch-all term when nobody really wants to commit to a specific pain generator? And maybe even more, should we be committing to a specific pain generator, or is that old news?
Right. So first of all, thanks for letting me nerd out on this, because I don't often get the chance, or when I do, people start checking their watches and phones for a way to get out of the discussion. But, I was presenting at ASMST this weekend, and, one of the slides was on phenotyping chronic low back pain. Where's the back pain coming from? And, the slide that I put up had 12 different images on it of all the different places that pain can come from in the spine. And, we all know that it can come from a disc herniation, it can come from pars defects, it can come from spondylolisthesis, it can come from ligaments, muscles, multifidus atrophy, so many different things. Vertebral body compression fracture, the hip, the SI joint, everything, right? So, spoiler alert, it more often than not is everything, and so if we just focus on the disc, and if we say, I'm just going to specialize in treating the disc, it's like my daughter calling me from LA last night. I'm in North Carolina. I thought, oh, great, she's calling me to chat. And no, she was calling me because she had a flat tire, right? So that gets at why is the tire flat, And is it because you got loose lug nuts? Is it because there's a nail sticking in it? Is it because there's a slow leak? What's going on? So diagnosing the problem is key, so she doesn't just keep on, having flat tires. So in my world, I think of discogenic pain as being something that is characterized by a couple different things. Axial low back pain, I think of more like vertical up and down as facet joints. Horizontal low back pain, kind of going across side to side, is more discogenic in my mind. The other thing that kind of sets off, an alarm or, raises my antennas is poor sitting tolerance. So someone who has poor sitting tolerance, I typically think of the disc as being, a potential pain generator. And so then we start, examining the patient, where are they hurting, showing us exactly where in their back they're hurting is key. Seeing if their multifidi and glutes are firing when those are tested. And then looking at imaging, right? A lot of times people come to us with x-rays and a CT scan, which are fine. Not a good place to start. But what we miss on those studies are the subtle things that are oftentimes very, very important. And those things include loss of water content. So you look at the T2 images and the sagittal and axial scans, and you see that, you've got dark disc disease at, 3, 4, 4, 5, 5, 1. And of course, the old annular tear, right? So that lights up with a high intensity zone in the annulus, sometimes very easy to see, and also sometimes completely unreported on the report. So if you're just looking at the report and you just see, degenerative disc disease, they don't mention the annular tear. And it's so bright, so white, and it's ipsilateral to their pain. And you're like, well, please, you have to look at the images. And so we see those. And then what else do we see? We see a lot of times modic change, modic type 1, 2 change. See the vertebral body end plates on either side of the disc are white, and well, why is that? And it starts to become a chicken and the egg discussion. Did the modic changes start and then cause the disc to degenerate, or did the disc have something go on and cause the end plates to react to what's going on in the disc? There's this one study, a surgical study, where they were taking out discs for disc surgery anyway. And a fairly good number of patients, I think it was 60, 70s, 80, something like that, pretty good number. And they sent off just pieces of the disc to the lab, sequenced it, and found that there was a 33, 34% incidence of P. acnes in discs taken out for surgery. And in those patients who had the positive cultures for P. acnes, they were 5 times more likely to have post-surgical radiculopathy compared to the people who didn't have P. acnes in their disc. So the P. acnes is getting in there. It's the same stuff. It used to be called C. acnes. It's on our skin, and it makes its way into the disc. It doesn't cause an infection, but it causes colonization. So, my belief is that there's probably some sort of trigger that causes the damage to start, but then the P. acnes finds its way in there and kind of propagates and causes a chronic condition, just like bacteria in the gut. SIBO, it's kind of like disc dysbiosis.
Oh my gosh, that's perfect. Disc-biosis. Yes, it's a dysbiosis, right? And,
Yep.
That when I heard about the fact that number one, discs are not sterile, and number two, that there's a microbiome inside the disc,
Yep.
and number three, when we have disc-biosis, that is very predictive of that degeneration. So the degenerative discs have a disrupted microbiome, whereas normal discs do not, which blew my mind. And I'm thinking, oh my, like, what else don't we know, right? And then the final piece is there are relationships between gut microbiome disruption and disc microbiome disruption. We're not going to go down that rabbit hole today, but I mean, this is crazy. And I'm so thankful that you've said you've got to get the right diagnosis first, right? And the likelihood is that it's probably E, all of the above. So I think the next question that we would like to know about is, what's the most misleading thing that patients are told about their disc problem before they ever reach someone who treats it, either surgically or biologically? What's like the thing that they all tell you and you're like, oh my gosh, not another one?
That it's going to get better and it's going to resolve on its own, over time.
Now, I think we talked about this, but is there some scientific evidence that shows that maybe some do?
So, yeah, I mean, first of all, what's the diagnosis? If it's a disc herniation, those are going to typically, resorb with time or, with treatment, whether it's chiropractic or physical therapy or just the passage of time, conservative things, inversion therapy, decompression therapy. It's almost like the bigger the disc is, the more likely it is to resolve. So that's probably true about, focal disc herniation or even a large protrusion. Sometimes even sequestrations, they're going to get better on their own. But these disc degeneration things, the annular tears, are the ones that kind of fall in between that classification system. Those are the things that don't get better and also recur. So if a patient gets that message, hey, this is going to get better on its own. Well, yeah, these people, the surgeons or the primary care are talking about disc herniations. And what about the person who is having these episodes where they just every, 6 months, 12 months, they just do something, they bend over to pick something out of the dishwasher and their back just locks up and goes out. They go through everything and they may not get, imaging. So, they may have had imaging 3-4 years ago and they're just in this mindset of, oh, I just got to wait for this to go away. I know it's going to be another 3-4 weeks. But during that time, they're miserable. They can't do anything. They can't travel. They can't work. They can't sleep. So it's just misery. So although that message may be true and scientifically it probably is supported, it is not the case for these other, I'm not talking about treating disc herniations. I'm talking about treating these degenerative discs with, loss of height, loss of water content, and high intensity zones. So it's kind of a different animal. And I think it defies classification within this, the framework of what we're typically told. So I think I disagree with the fact that these are going to get better. And, I had a great example of this, unfortunately, the other day, someone I treated 11 years ago. Okay. I saw her last week and I treated her 11 years ago with a single facet cyst aspiration. Okay. So that's all I did. And the next time I saw her was last week, 11 years later. And she had some disc degeneration when I saw her. And she had a bigger problem with the facet cyst causing a radiculopathy. So drained it, and obviously complete success, right? Well, she has developed grade 2 spondylolisthesis, almost complete collapse of that disc at the level where that facet cyst occurred. And so her lack of symptoms did not help her. It helped her to live 11 years, but now she is looking at a situation where I can't help her. There is nothing to help at that L4-5 level. I cannot help her with needles. She's going to need screws and rods. And so that is my concern for anybody who has disc degeneration. And that is kind of my motivation for treating discs in the extreme situation. Greg Lutz's book, Heal Your Disc, End Your Pain, has a great picture in there of the same exact thing. Someone who, didn't get treatment for her discs and ended up having the same thing, disc collapse, disc spondylolisthesis. So if you have instability at that level, due to, more likely than not due to some disc degeneration, which then weakens and loosens, the ALL, PLL, and, the other supporting structures at that level, you're going to end up with what she has. Now, can we fix that? Can we, stop it from happening? Can we reverse it? That's the question. Can we do this with biologics? Maybe yes, maybe no. But I think it's critical that we think about it.
Yeah, starting that upstream thought process to say, okay, if we treat it now, can we avoid fusion in the future? Now, did you look back at that woman from 11 years ago and go, dang, I wish I would have done PRP and her annulus, and shoot, man, we really missed the boat on that?
Well, that was 2015. And I was not thinking about intradiscal injections back then.
Exactly.
That was early. I mean, that was the year, I think, before Matt. I was looking the other, Patine, Matt Murphy and Patine, I think that was 2015. So that was probably the earliest I was thinking about treating discs, at very, very early. So that wasn't even on my radar back then.
Yeah. If that same facet cyst came in today, would you be more aggressive?
Well, I would ask why. Why do you have a facet cyst? There's either clinical or subclinical instability there. That doesn't happen for no reason. And so I would absolutely try to convince that person to treat her condition with a biologic as opposed to, a potent, immune suppressor in steroid that's just going to, obviously fix her symptoms, but it didn't do anything. I don't think the steroid caused her spinal column to collapse, but it did nothing to address the biologic insufficiency that she was having at that level.
Yeah. So that's such a good thought process. So clearly we have more questions. So buckle up, Buttercup. We're getting down to this.
Let's go.
Right?
Bring it.
So, if PRP works in joints and tendons, why are so many physicians still hesitant about intradiscal PRP? So is it the evidence, technical challenge, fear of discitis? What do you think is like that biggest hang up? I mean, I can share my experience as well, but what do you think that biggest hang up is?
I think all the above. As having had someone who's caused one discitis in their 30-year career, I can say, and it was with bone marrow concentrate. We were kind of everyone was kind of echoing the sentiment that bone marrow concentrate is very antibacterial, and it wasn't just me. It was me and my partner who had one case of discitis using bone marrow concentrate, and at that time there was more information coming out from Greg Lutz about leukocyte-rich PRP. So why is that? And I know speaking to some people that we mutually know, just seemed the person I'm thinking of seemed comfortable with the like 1 to 2% incidence of discitis, and it's just for me that's not in my DNA. I cannot. It really, really upsets me when I cause someone to have a condition like discitis. So fear of that is a big thing, I think. And the other thing is that we can manage a lot of the symptoms from discs by just treating with the functional spinal unit approach. So, I think that's a very effective way of treating and managing symptoms, as long as you're also monitoring radiology along the way. So you can say let's go mostly on pain and function, but also agree that we're going to take a look at your MRI in another year, year and a half, to make sure that we're not seeing progressive spondy or something like that.
Oh,
So there are
that's really good.
are
Yeah.
ways of, yeah, why not?
Yeah, yeah, yeah.
And so I think that it's probably anyone can do a discogram. I think it's not that complicated, but post disc biologics are a lot more uncomfortable than your FSU procedure. So that's another reason. I think once people have done it, they realize, I got to kind of handhold for a certain percentage of these patients for a good couple of weeks, and it's maybe something that they're not really too keen on.
Yeah, yeah. I mean, right now I'm not currently doing intradiscal. I think I've shared with you
Hmm.
that I am trained as an orthopedic surgeon with an entire year of spine orthopedic surgery training, right, under my belt. And so then, to learn how to do the injection-based therapies is pretty straightforward and simple. And yet, I'm like, I don't know. And then, the other pieces, it's all like degenerative discs, all in theory, are already inoculated, right? So are we really causing discitis, or are
Yeah.
those just the ones that kind of get out of control and they're all kind of inoculated with P. acnes, and then, 1% of them get out of control? I don't know, you know? I don't have that answer.
Yep.
But that for me,
Um,
the discitis
so
issue
the things that
is making me nervous.
So we used to use cefazolin for our antibiotic when we were doing intradiscal procedures, and that's pretty standard for people even today. Even though some really good data from Lutz's clinic showed that gentamicin is much better in terms of killing those bacteria. So that may or may not be the reason we haven't seen. We've seen zero intradiscal any discitis since 2018, when those both occurred, and that's through the use of gentamicin, anywhere from 200 to 400 mics per cc in our contrast, and then leukocyte-rich PRP, at very kind of strong doses of leukocyte-rich PRP, like 80 cc's of blood being spun down to 2 cc's of injectable leukocyte-rich PRP. So it's really high dose. Platelets seems to be also very antibacterial. So knock on wood, I don't feel hesitant about injecting discs, other than, counseling patients about their increased levels of pain afterwards. And then also it's more costly. When we inject the disc, it's going to be more expensive.
Gotcha, gotcha. So, you recently, I was calling you on the phone. You're like, "Hey, I'm at this conference with the Discseel," and so Discseel is based on this idea that
Mm-hmm.
the annular tear is the issue, not the disc height loss. So, what do you think about this? Because we've been talking about getting the right diagnosis, and we've been talking about that probably all of the things
Yep.
are taking effect. So, how do you kind of reconcile that?
So I think the sensitized nociceptors in the annulus are probably a big source of pain for people, and it gets sensitized because the chemicals from the nucleus pulposus are leaking out into the rents in the in the annulus, and then in cases where it leaks all the way out, whether if it's a full thickness tear, it's going to leak into the epidural space. So I think sealing those tears is important, and the knock on PRP and bone marrow concentrate from the manufacturers of the Discseel are that it leaks out, and it does. It's pretty fluid, and despite us wanting to think that it coagulates inside the disc and forms a clot inside the disc and really plugs it up, it really doesn't. I mean, it stays pretty liquid, and even if you're being patient and you're injecting little bits of aliquots at a time. So I wanted to check out Discseel just to see what it was like physically, and what it was like as a biologic preparation as a glue. And it's I don't know if it's 100 times better as a glue than PRP. It just is, but it's not PRP. It's not, it's allogeneic. It's coming from pooled human serum, and so it's got its pros and cons. Some people are reviled at the idea of injecting this into your spine. It seems like a terrible idea to them, but I think it's a reasonable tool. I'm glad I have it. And one of the other things that kind of was motivating me to look at it is that it's the only biologic, even though it is allogeneic, it's the only biologic that's covered by the VA for their patients who have, degenerative disc disease. So that's been something that I feel pretty strongly about. We're part of the, VA community care network, so we take care of vets with whatever they need, spine joints. But this is something that's unique, and they did, Paz's group put out a pretty large number, 700 plus patients, observational, so it's not level 1 data, but it's, a fairly good number of patients that I look at as having, a strong safety profile, no serious adverse events, and pretty good durability in terms of pain of function going out three years. So I think it's reasonable, because newsflash, there is no level 1 evidence yet, that we have something that is, the bee's knees for disc, and that's, maybe going to change with some of these phase 3 products that are in the pipeline. But, right now, Discseel is definitely not level 1. Viadisc is the other thing that they're doing a phase 3B right now, looking at Viadisc compared to a sham procedure, because they did Viadisc versus saline. It turns out the saline is a pretty good drug to inject in your disc, so it really didn't separate out from saline in their initial. So they're working on it, but still, I've never really thought that was something I wanted to get into too much, because it doesn't make sense to me. The nucleus pulposus in the disc is full of noxious chemicals, and injecting that, even though it's from a healthy volunteer, into a damaged disc just has never made sense to me. The fact that it didn't separate out from water in their first trial, the VAST trial, was not too thrilling to me either. And it ain't cheap. It's not covered by many insurances, so it's not cheap if you want to do it.
So if you were putting a head-to-head trial together and you were offered either Viadisc or PRP, what would you choose?
I would use PRP.
Yeah. Okay.
I think it would be an easier sell for most patients, and I think you do have to compare it to something, a sham, as opposed to a vehicle like hyaluronic acid. I think the sham is the only real way to judge it against as a placebo.
Yeah, and maybe with a crossover or something like that.
Mm-hmm.
Absolutely. So, what's that uncomfortable truth about why disc regeneration, disc injection, Discseel, why is this not mainstream yet? Is it the science? Is it the economics, the training? To be honest, is it the surgical culture?
Simple. I mean, I presented to, well, it's level, it's the level of evidence that we have supporting it. All these studies are super small, and that's all that a surgeon needs to hear in order to just dismiss it, right off the bat. No offense. I mean, most spine surgeons. So every single surgeon at this event, North Carolina Spine Society had, they were listening politely, but just said, what's the level of evidence? And when you tell them about the numbers of patients in these trials and studies, it just doesn't impress them. And the fact that it's not FDA approved, not standard of care. It's just self-fulfilling, prophecy. You're not going to change minds until you have something with the scientific data behind it, even though a lot of the spine surgeries that are done really don't have that either.
I was just going to say that, as we saw recently from John Buford, that for the top 5 impact journals in orthopedic surgery, the average level of evidence is level 3 evidence. And so as
Yep.
much as we want to think we're practicing with level 1 evidence, level 2 evidence, I think we may not be practicing as high a level of evidence as we probably think or wish we would. So here's the next question for you. If someone already has a fusion and they develop that adjacent segment disease, are orthobiologics a real option, or are we just trying to delay the next surgery, or should they just get it over with and fuse the whole thing? What are your thoughts and experience on adjacent segment disease?
You're just gonna push the lever arm further up or down the spine, the more levels you fuse. So, and I've seen that if you can delay, the quote inevitable, I think you're offering patients, surgical free time that you can, realistically provide some meaningful improvements in pain and function. I've treated a lot of adjacent segment disease, mostly with PRP, intradiscal, and the key also with the PRP approach is that, let's just say it's not the disc, let's just say it's the disc and the facets and the ligaments on either side of that fusion. We just, by definition, are treating everything. I think there's a lot of times facet joint diffusions that we see and are sometimes missed because they're not facet cysts, but it's a lot of evidence that looking at us on MRIs, if we take the time to look for them. And then obviously it makes sense to just not treat the disc, treat the facet joints in these people, and treat the ligaments, treat the SI joints, when it's a L3 to L5 fusion or L4-5 fusion, that bottom disc and SI joint are just getting jacked up. And so we obviously treat the ligaments and SI joint commonly. And so that would be the thought in adjacent segment disease. It's oftentimes more than just the disc. It's the other things as well.
So how do you counsel your patients when they come in and they have pretty significant adjacent segment disease? What do you tell them? What can they expect?
Well, in terms of if we treat them with PRP, you mean?
Yeah. So you're like, oh my gosh, you're a candidate. You're gonna do, great or pretty good. What do you tell them? Is this a one and done? Is this something where you're gonna do PRP and then monitor them in the next, 18 to 24 months? What should, if I was coming to you for treatment of adjacent segment disease, what do you tell me?
So typical plan would be to say, if we're 100% sure and on the same page that we want to inject the disc, and we do everything right off the bat, including the disc. If there's any question that, either from a financial standpoint, they don't want to, really kind of go all in at once, or they feel like the recovery after an intradiscal procedure might be a little too much for them at that point in time, then we treat everything except the disc and then wait for a good 6 to 8 weeks. And if they've achieved, significant milestones in terms of pain and function, we leave the disc alone and just monitor. And if they've kind of had a so-so response, then I would say that we just go for the, round 2 would be just intradiscal. For the most part, if we have a normal recovery process, for the vast majority of my patients, 60, 70, 80%, are going to be one and done. Very few people will have, a boot injection. Some of those that do, maybe more of the high level athletes who just want to have it done because they feel like they want that extra dose of platelets. But for the vast majority of our patients, 95% of them, it's going to be a one and done. And then we just monitor as time goes on. So that, patients who get the FSU where you're not going into the disc, it's going to be maybe a week or so of discomfort. Might be use a little Jornavax, that new sodium channel blocker, non-narcotic, not addictive. We'll do that for a week to 10 days for some people. If we go into the disc, I tell people 3 days to 3 weeks of pretty elevated levels of pain. Kind of like I'm happy when it's a person who's had these severe spine blowouts where they can't move, they can't, twist, they can't turn over in bed, because I tell them that's what I'm going to do to you, for the most part, over the next, 3 days to 3 weeks, and sometimes even longer if we're using the via disc. That can be, go out a couple months before people start feeling like they're really turning the corner. So a lot of different things come into discussion when we're talking about, do we inject the disc or do we not? Are you prepared? You're not going to, big trips coming up, no weddings, no, anniversaries that you're taking a big trip for. So you have to make sure patients are aware of the morbidity that can be associated with these things. The FSU is pretty easy to recover from, but the intradiscal stuff can be a little bit more unpredictable.
Amazing. Yeah. Thank you so much for sharing
Yeah.
that. I know that everyone who's listening is going to be able to take that home and have those conversations with their patients about, expectations of a functional spinal unit, which is basically treating everything, all pathology with PRP versus, that intradiscal experience for the most part. And have you stopped doing bone marrow concentrate intradiscal at this point?
I have. Yeah, I have not done that since that discitis.
That faded
That was,
day.
yeah. I mean, it was bad. I hated it. And we've just had good results, really good results with the PRP. And, it wasn't a perfect study, but Anu Devani did a study, maybe 23, I think. And she showed that, intradiscal PRP and bone marrow concentrate had similar outcomes. And yeah, it was a small study, but I'll latch on to something like that. If it gives me an excuse to do something that I feel is safer, I'm gonna use that. And so I'm glad that was done, and I'm glad that I have the data to back it up when I'm kind of explaining risk profiles to patients about the different techniques.
Awesome. Awesome. Well, so, this has been so great. What a wealth of knowledge. And I really appreciate this consideration of like how to deal with these patients. And is the disc the end all be all? And, some of it is, some of it isn't. So thank you so much. So what is that next step to be successful in our practice? Well, we have a system, our orthobiologic practice launch system, and we know that we've gotten that orthobiologic knowledge from you. Now, the next step is to use all this knowledge for the right patients, the ones that need your help. And then finally, obviously creating a cash-based practice as it's not covered by insurance, helping to have those high converting consultations where these people are awesome candidates, but they don't maybe know everything about these orthobiologic treatments, and then clearly putting it all together for success. So if you want the fast track, I have a little quiz for you all. So if you're watching this on a computer, please just scan this QR code, and this will help you evaluate your next steps and evaluate your capital outlay, clinical confidence, workflow readiness, and legal freedom. And this will help you understand where you are in building and launching your orthobiologic practice. So please make sure you scan that QR code. And then I did want to invite everybody to this amazing 3-day event that we are hosting to be able to engineer your predictable cash pay practice. It is in Scottsdale, Arizona, June 5th through the 7th. And this includes some MMSK, shoulder primer, AI practice tool implementation blueprint, cash pay revenue infrastructure framework, and private personalized implementation environment. So I really would love you all to come. This is that early bird pricing before April 1st. Go ahead and scan that QR code. You can check out the full website, and we'd love to have you to be able to fully launch your successful cash-based practice. So John, I am going to turn it over to the Q&A. We've had a bunch of discussions. If y'all have any questions we've got a ton of questions. So we're just going to go ahead and start picking them off. This is so great. So so there's a lot of questions. A lot of people are struggling with marketing. If you're struggling with marketing, please come to our event. We have a full marketing day on what the heck to do and how to do it right. But we have a question for you, John. Do you use PRP with Discseel? And, when would you use either as a standalone treatment?
The majority of my Discseel patients right now are VA. And so VA will pay for the Discseel, but they won't pay for PRP. I could imagine that they might get a little squirrely if I was combining PRP with their Discseel patients. So I would probably do that sequentially in a VA patient if they needed it, if I felt like they had some nerve root irritation or something of that nature on a different day. But I have so far not combined PRP with Discseel. Now, there are some people that are doing that with their cash pay Discseel patients, epidural PRP and intradiscal platelet Discseel, which I think is fine. And, maybe I've thought about putting either a leukocyte-rich PRP into the nucleus and then kind of sealing it in there with the Discseel. I think that is interesting to me. I've also thought about injecting platelet lysate. There are some early studies from Makeda back in 2015, 2014, just using platelet lysate in the disc. So as long as it's not like that culture media of bone marrow concentrate, and I'm using something like gentamicin, I think you could kind of get pretty creative about ways to add a biologic into the disc that's got growth factors and some cytokines in it, because the Discseel, I don't think anyone's ever looked at the proteomics of that in terms of growth factors or things like that. It's not what it's designed to do. But yeah, I think it's a good question. I think you can combine them safely. Reasonable thing to do.
Yeah, so there's a question. What about platelet lysate, especially on, nerve root irritation or epidural or, hot radic kind of
Yeah.
patients? Is that what you're using
Yeah.
that for
Yeah.
usually?
Well, I'm a big fan of platelet lysate. You've seen our setup for that. It's a great product because you're kind of cracking open the eggs before you inject them, right? And so you don't have to wait for that aggregation and degranulation that occurs in vivo. You do that ex vivo, and you've got all those growth factors and the IRAP and the A2M ready to go. So we use that quite a bit and almost exclusively for transfemoral injections. Definitely cervical spine. I don't feel great about using straight PRP in the cervical spine at the foramen, but we use platelet lysate all the time in the foramen because it's filtered. We filter it down from 15 microns down through 0.2 micron filters, and so it's really particulate free. So we don't have to worry about that radicular embolization that you would potentially with some platelet clumping. So I love that a lot. I use straight PRP for my interlaminar epidural, so I don't think you really need the lysate in the epidural space because those it's gonna stay in the area where you inject it pretty well for the time needed for it to do its thing, degranulate and release the platelets in that way.
Yeah, that's a great question. When we compare, or when you are thinking about lysate versus PRP, what's your expected differential in time to relief?
I think we were already using plasma concentrate, PC, in our epidurals. That goes back to 2017, that we were using the earliest HPH filters to get at that. They were originally in the selling devices, integrated into the selling devices, Matt Murphy's device there. And so, the idea came from that. But then when we kind of moved away from the selling company, we found that we could get those filters directly from Medtronic. I think we were getting them from. And so then, we use a different vendor now. I'm not sure if I can say their name, but we use them and they're great.
Whatever you want, you can absolutely.
Apex. Yeah, the Apex filters are so great. It's like smaller kilodaltons just get you so much more of the good stuff out of the plasma that we used to throw that away. So we've
Right.
not been throwing it away for a long time, and I really like the evolution of the Apex filters because that to me has. I was always surprised at how quickly these people, I just injected like 40 places in your spine, and like I see them back in a week and I was like, how you doing? They're like, I'm good. Like, what? I can't believe it. So just for those super hot radix, platelet lysate, yeah, I think platelet lysate just has that extra oomph. It's full of these, really potent IRAP and A2M. Ben Ross, and you saw his study on those massive disc herniations that he was just using epidural and transforaminal platelet lysate, and I felt like he had like, yeah, it was just like study after like case after case of these like very rapid and complete resorptions of these massive disc herniations due to just platelet lysate. I was like, Ben, you've discovered the insulin of massive disc herniations. So I like it for that indication quite a bit.
So our friend here is asking, there's a MRI showing C4, C5, C6 disc prolapse, pain-free, but noticing gradual weakness of the left hand, arm, and legs. Thought about PRP intradiscal to reduce that prolapse.
Well, Ben, I hope it's not you,
I
but
know,
something
right?
tells me it is.
Our friend,
Well,
dear
yeah,
Ben, we hope you're
a
better.
friend down under. Well, I think yeah, if you've got weakness going on, depending on how much compression is going on at the DRG or the cord, obviously weakness is very concerning. But I've seen weakness resolve just with epidural,
Epidural
intralaminar and
PRP,
transforaminal.
right?
Yeah, I've seen it. Yeah, I've seen it resolve with just using PRP epidurally, not even intradiscal. So, if you haven't had epidural PRP, I would definitely hit it hard and hit it a number of times. Both transforaminal and epidural. Maybe before going intradiscal. Reasoning being that I think if you go intradiscal and you have just an increase in inflammation, which is very potential and very likely actually, I would just hate to see that making the weakness worse, and that might push you more towards a surgical approach sooner rather than later. And I would say that it's very unlikely to push it over into like a flare-up situation if you're doing epidural. So that would be my suggestion. Try to be an incrementalist, right? Do the epidural stuff first.
Incrementalist.
Do the epidural stuff first. Yeah, baby. Let's go.
Yeah.
So, but
Perfect.
Ben, get over here and I'll treat you myself,
No
mate.
kidding. Go fly over there, my friend. Okay, so we have a question. How is it working with the orthobiologics with PRP with health insurance? Is it extra cost to the patient, or is there any strategy to use it in the hospitals? Uh, Rarely is it used in the hospitals because they haven't figured out how to actually take cash. There's a lot of university settings that are doing it, and there's a lot of the university settings that are their regenerative programs are going under because they can't figure out how to take cash. John, what are your thoughts on
Yeah.
insurance and PRP in the hospital?
I mean, I think it's great that you got a lot of people who are at these university programs who are doing it. I don't know how they're doing it. Maybe I don't know, but in our country, unfortunately, it's not available for people who are trying to use their insurance.
Yeah.
I don't think there's any hope that that's going to change in the near future. So it is something that is 100% patient responsibility. If they want to get it, they have to pay cash, and we have to actually have them in our country, whether there's commercial insurance or Medicare, we have to have them sign a form that specifically says we are not going to bill your insurance for this. You will be 100% responsible for it, and they either have a payment plan or they pay up front with a credit card. So that's at least in our country, in our state, that's how it is. I don't see that changing with insurance anytime soon.
This is an interesting question. So, would you recommend PRP or Discseel or lysate if you're pairing an intradiscal injection with a discectomy procedure? Like take out the herniated disc and then seal it, and then put maybe
Oh yeah.
lysate or
Yeah.
epidural. Like, man, that'd be pretty great, hey?
Yeah, I mean, recurrent disc herniations are a big thing, and I've talked to my surgical buddies about that, and they say unfortunately it gets, they're creating a pretty big rent in the back of the disc sometimes, and I think disc seal is great, but it's more for like it's kind of like a slime for a tire. Like if you have a puncture hole, slime, you can put that green goo inside your tire and it'll fix that. But it's not going to fix a hole created by someone using a knife to cut a hole in the side of your tire. It's just not that good. So I think if you're just taking out a kind of a pedunculated, herniation that with a small, area where it came out of the disc, sure, try to seal it up at the time of surgery. But again, you're talking about cost. I mean, it's a pretty expensive drug to use.
Now,
And
tell me this. Can you just use Discseel?
you can use, that's what it is. It's Discseel, but it's not cheap.
Fascinating, because like we use that in orthopedic surgery all the time.
Yeah, I think if you're buying it from Baxter, it's one of these things. It's a couple grand. So I think
Yeah.
without being able to tell a patient that this is definitely going to help you, I don't know if you could get it covered with their surgical procedure or not.
Yeah, I don't know either. Report back. Let's try that out and report back,
Yeah,
right? Quick
yeah,
question. Any
yeah.
success with motor vehicle or personal injury with any orthobiologics? Oh my God, yes, all day on Sunday, right?
Yeah. Stopped kind of
Third
doing
party.
PI a while ago. We don't see any third party. We don't anymore.
Yeah, yeah. So, I think third party and motor vehicle, maybe. I have some friends that do a ton of PI and do a lot of orthobiologics, have a lot of success with that. Just get them to pay up front. So awesome, awesome. So Jonathan Parison is going to he sees the cost benefit analysis might be there, and thanks for the response. And he'll report back if he ends up putting a little Discseel after pulling out a little herniated disc. That's awesome. So good, so
Love
good.
it.
Okay, so anything that you want us to know about you, how to get a hold of you, reach out on LinkedIn, look at your website. Please let everybody know how to get a hold of you.
Yeah, so I'm on LinkedIn pretty much every day, and if you just connect with me, I'll connect back. And if you are interested in seeing kind of my philosophy about regenerative medicine, our YouTube page is Elite Spine and Joint. It's Elite Spine plus sign joint, but I think if you just put that in there, you'll find it. There's a lot of greens and grays and whites on ours, so look for that, and you'll see my face among the videos.
I was just gonna say, and it's
then
you.
our website is www. And it's me, just this face, right there. That's me. So, and then our website is www.elitespinejoint.com. So,
Awesome.
yeah,
John, it
reach
has
out
been
and I'm
so
happy to
fun.
share knowledge.
Yeah. Oh my gosh, so good. We always nerd out about this stuff. I think we
Yeah,
just invented a new surgery, so congratulations to all of us. And Dr. Paris is
good
gonna
deal.
report back on. He's gonna do 20 of them, and then we'll have an amazing series that'll look at that. So awesome. This has
Love
been
it.
so great. Yeah, I think Ben Sibley might actually give you a ring. So
Yeah, I'm waiting,
don't
Ben.
put it
Come
off,
on, mate.
brother.
Let's go.
Perfect. All right, guys, this is the top of the hour. And, John, thank you so much for sharing your time. Everyone else, thank you so much for sharing time. We will be back here in 2 weeks with an amazing set of questions regarding peri-procedural nutrition and supplementation and what works, what doesn't, what the science supports and how that supports it with the great and so super smart Dr. Jordana Quinn. So I hope to see you in 2 weeks for all of that peri-procedural, very, very nerdy science stuff regarding what supplements we should be helping to stimulate and improve our patients in this peri-procedural orthobiologic timing. So I'll see you guys next time. Thank you so much for everyone sticking around. And John, we'll catch you on the flip side. Everyone else, thanks so much. You guys have been truly great. Happy St. Patty's Day. Go pinch somebody, please.